Let's talk about aneurysms. We've encountered aneurysms before. They are outpouchings or balloonings of a blood vessel. And where have we seen them? At the junction of the internal carotid artery with the middle cerebral artery. And that can be called a baryaneurysm. And then when that pops, that's a subarachnoid hemorrhage, which is a life-threatening condition that happens to many, many people. So aneurysms can kill depending on the artery they develop in. And they can lead to organ failure even if they're in the smaller organs. And the reason why aneurysms are so nefarious is due to the law of Laplace, which we've just recently learned. And the law of Laplace says that the tension on the wall of a cylindrical vessel is going to be approximately equal to the pressure of fluid within that vessel times the radius of that vessel. And so once the radius of a strip of artery starts expanding, because that's what's going on during an aneurysm. Once the radius starts expanding, well, you can't ever slow it down again. So as Goyan says, it's not if an aneurysm ruptures, but when it ruptures, because it will pop. It can be a true aneurysm or a false aneurysm. The false aneurysm is really fascinating because it's basically a blood clot patching up a hole in the wall of an artery versus a true aneurysm, which does not have a rupture or a hole inside that wall. And atherosclerosis is the #1 risk factor for true aneurysms, but then for pseudoaneurysms, trauma to the wall of the vessel is going to be your #1 risk factor, and that can be inflammatory, as in the case when you have some sort of vasculitis maybe, or that can be mechanical trauma, as in the case with a heart catheterization, or anytime you need to take an angiogram of something, you have to put a catheter up in there. And so that's a common route for the development of the hematoma, characteristic of the pseudoaneurysm. And they can be saccular or fusiform, and fusiform is going to basically have 360 degrees of involvement versus saccular, which is going to have a sidedness to it. So the AAA, the abdominal aortic aneurysm, is one of the most common aneurysms that a human being can get. And the reason why it's common is just like in the subarachnoid hemorrhage, there's an area of weak artery. And so in the brain, we know that the junction of your internal carotid with your middle cerebral, it kind of makes an angle like that. And at the crux of that angle, at the fulcrum of that angle, you've got this area of weak arterial wall where you don't really have a tunica media. And something similar, not identical, is going on with your abdominal aorta, in the sense that your aorta has a blood supply, and that's called a vasa vasorum. But below the level of the renal arteries, the vasa vasorum stops. And so your aorta no longer has its own blood supply. And so it's dependent upon the diffusion of oxygen through the wall of its own lumen in order to supply its own media. And it's got a big media, right? So that's why you get abdominal aortic aneurysms, most common aortic aneurysm. Hypertension predisposes you. Again, pressure goes into wall stress. Smoking predisposes you, and we'll see that's largely due to the degradation of fibers within the wall of your aorta. And then this couple of sentences at the bottom of the case presentation basically tells you what you're going to see on histology anytime there's an aortic aneurysm. It's an easy diagnosis to make because they've got to either show you a picture of it, or they have to tell you that there's a pulsatile mass in the midline of this person's abdomen. And so both of those there's not much else it can be besides a AAA, especially if it's an at-risk population patient. And so you see a loss of elastin in the wall of the affected blood vessel. And you see a lot of fibrous scarring, and collagen is not as flexible as elastin. And so with continual hypertension, obviously that's going to lead to a rupture over time. And then there's neovascularization of the media because that media is going to be hypoxic, proportionate to the amount of scarring that's going on within that wall. So there's the spatial definition of a AAA: 1.5 times its normal diameter or greater than 3 centimeters. It's going to affect old people. It's pretty common, 5 to 7% of the population. But the reason why you don't see it in more people is because a lot of people die before they can even get the chance to develop this sort of chronic degenerative pathology. And we're going to classify where it's at relative to the kidneys. It'll be suprarenal, pararenal, or infrarenal, obviously above, at, or below the kidneys. And the diagnosis, again, is going to be a pretty easy one to make in a question stem, not saying in real life, but certainly in a question stem. They have to either give you an image that looks like this, or they have to give you a pulsatile abdominal mass, and the patient's going to be in a whole lot of pain, and it's going to be in their front or their back, depending on what side of that ruptures first, or if it's retro or infraperitoneal. And then you can get intermittent claudication too, because AAAs are right next to the femoral arteries, right? And so if there's any hemostasis, any clotting that's going to occlude one of those femoral arteries, well, then obviously that's going to lead to a hypoxic ischemia, and that's how you get the bluish discoloration in the lower extremities there. It's not too difficult. Risk factors, significant. I think this is probably a test question, very popular and easy test question. Smoking is number one by far. And so it could be the sort of question where they throw you atherosclerosis, and maybe sedentary lifestyle and old age and a lot of things that seem like they could be the number one risk factor, but it's smoking. There's some negative risk factors, which are interesting. Diabetes, I don't quite know the mechanism behind that, but African-American ancestry and women. Basically, white men tend to get AAAs, and nobody else has it in nearly as high as a proportion, although it can happen in other populations. And then you can sort of acquire a AAA through a nutritional vitamin C deficiency, or even through an iron deficiency anemia. And the reason for that is because you need vitamin C to cross-link your collagen. I think that's prolyl hydroxylase. It's proline that's getting cross-linked, and then iron is a cofactor for that enzyme, and so an iron deficiency anemia is going to give you basically the same effect on your collagen as a vitamin C deficiency, and we know that causes scurvy. Well, the same mechanism can take place in the wall of your aorta and lead to its dissolution over time. And smoking is associated with vitamin C deficiency, coincidentally. And smoking increases your AAA risk 5-fold. It's a very, very strong correlation. And we think that's because smoking inhibits alpha-1 antitrypsin, amongst other enzymes. Obviously, smoking is a very, very multifactorial hit. But we'll get to alpha-1 antitrypsin in a minute. So on histopathology, what do you see? Well, you're going to get a slice of the aorta. And so you're going to notice a large, prominent tunica media with a lot of elastic fiber in it, and then you're going to see an adventitia with a vasa vasorum, and so that's going to let you know this is the aorta on histology. And so you're going to have a thinning of the medial wall. Remember that normally in a large elastic vessel, the media should be much larger proportionately than the adventitia, but here you can see that the media and the adventitia are of relatively the same thickness, and you can interpret that as medial thinning. And you're going to see an infiltration of lymphocytes, macrophages, immune cells. You're going to see neovascularization of the tunica media, and we've said that's due to the inflammation that comes with a hypoxia as cells start to get agitated. And you're also going to see lymphocytes surrounding the vasa vasorum. I don't think you'll see that every time. I can't really explain that off the top of my head. But number one finding is that all the elastin that should be in the medial layer of the aorta is going to start to fragment and break apart. And we know that elastin stains that wavy, squiggly black. And so you're going to see a lot less of that wavy, squiggly black. That's going to be the number one sign, and it's going to be way easier for you to spot than the proliferation of the vasa vasorum. It's like you kind of got to look at a square for like a minute or two before you see that. So the elastin, that's how you make the call histologically. Is it there or not? Here's an example of the vasovasorum surrounded by immune cells. See, immune cells I can get because anytime there's damage to the aorta, right? Well, immune cells have to extravasate into the tissue, but they don't do that through the big old wall of the aorta because it's a big old wall, you know, it's like build a wall big. And so they got to get into the wall of the aorta somehow, and they do that by extravasating through the endothelium of the vasovasorum. And so they'll grab onto ICAM or VCAM or whatever cell adhesion molecule, and they'll roll and they'll go into the wall of the aorta. And that's how you get all these immune cells there. So that part makes a lot of sense. But specifically, why is it lymphocytes? Yeah, you got me on that. So there are three sort of pathogenic factors going into the development of a AAA, and they're all related to the breakdown of that wavy, squiggly black elastin, and then the replacement of elastin with collagen, which, as we know, is not as stretchy as elastin. It's scar tissue. And those are genetics, check. One can be predisposed to having less elastin, right? Or maybe it's a hypertension genetic factor. Inflammation, and gross inflammation is going to, local inflammation is going to signal for immune cells to want to go into the wall of the aorta, like we just said, and they're going to multiply all of that inflammation through their cytokine signaling. And cigarette smoking is a really big source of inflammation within the aorta because it's got this anti-1 or alpha-1 antitrypsin enzyme that works in the lungs, and it's a protease inhibitor. And because it's a protease inhibitor, well, whenever you remove the protease inhibitor, proteases can start working and they have a higher activity rate. And so what do these proteases cut? Well, in the case of trypsin, it can cut elastin. So if you remove the protease inhibitor, you inhibit the inhibitor, you've got more protease activity, you're cutting up all the elastin in your aorta. That's the number one of many mechanisms behind why cigarette smoking leads to AAAs. And then proteolysis. Oh, this is saying that matrix metalloproteinases are released by the macrophages. And matrix metalloproteinases are essentially scissors. They're enzymatic scissors, and they go around cutting up the extracellular matrix. And then whenever they do this, macrophages and smooth muscle cells throw down collagen to fill in the holes in the extracellular matrix. So activated macrophages, specifically M1 macrophages, are going to release matrix metalloproteinase 2. And then when they go into their M2 macrophage phase, they're going to start to lay down collagen wherever that MMP chopped up elastin, fibrin, etc. So we diagnose these with ultrasound. I'll label this. Here is your aorta, right there in the middle. And it's slightly left of midline, right in front of the vertebral column. Right here, you're seeing the poles of the kidneys, and you're seeing some large intestine. So that's where it's going to be. And then the blood can spill either into the peritoneal cavity or backwards away from the peritoneal cavity. That's retroperitoneal. And so most of the time it's going to be backwards. And so that's why patients going to have flank pain, because it's behind the cavity that's housing all of their abdominal viscera, right? And so if it pulls back here, well, then the patient's not going to have pain in their front. But then if it pulls where the organs are, watch out, that's a tough case to operate on. So we diagnose it with ultrasound. You can get CT if you want. CT is nearly 100%. I think CT might be the gold method diagnostic, gold standard diagnostic method, whereas ultrasound's how we screen for them, not quite diagnose them. So most AAAs never rupture, and again, that's because people die of other means before their AAAs rupture, but a AAA is going to rupture eventually due to the law of Laplace. And what is it going to present as? What's the picture look like when it ruptures? Extreme pain, 10 out of 10, 20 out of 10, 50 out of 10, you know, and when they say it, they mean it. Typically retroperitoneal, so you're going to get flank pain around the height of the kidneys. You can see a bruise, and the bruise is going to be all that oxidized iron in blood cells, and blood cells are spilling everywhere and popping open. That's where the bruise comes from. Typically going to be a hypovolemic shock because they're bleeding. It's like they have a gunshot or a stab wound, right? But it's inside of them, not outside them. So that's the hypovolemia. And then that's going to be associated with a drop in blood pressure and a compensatory tachycardia. They're going to be blue, and they're going to have a headache, certainly, and they might pass out because they're not perfusing their brain. And you're highly likely to die from them. And so this paragraph here at the end of it is basically, that is what you're going to see in a question stem. That is the diagnosis, you know, and they have to give you the majority of what's here in this paragraph if you get asked a AAA question. So just know the presentation and be prepared to answer any questions about the risk factors, histology, or pathogenesis. Let's talk about dissection. An aortic dissection is blood in between layers of the aorta, and we know it's got 3 layers. And so if blood, fluid, mobile blood gets pumped through a hole, an intimal tear in between any of these layers, typically the intima and the media, then the layers of the aorta split apart, and that's a dissection. And this is also a pretty emergent pathology. Still in the clinical example here, telling you some more of what you'll see in a question stem. Benign nephrosclerosis, where have we seen that before? We've seen that with hyaline arteriolosclerosis, that large granular sort of hills and valleys, contractile scarring of the kidneys. So what that sentence is saying is the patient demonstrates anatomical evidence of hypertension, and hypertension is going to predispose you to a dissection. And then on histopathology, you've got separation, as you see in this picture here, of layers of the aorta, and then there's fragments of blood clot in between the layers. You see a loss of elastic fibers because they get ripped apart. You know, they separate from one another. The layers do, just due to the pressure. And then you have a ton of GAGs, glycosaminoglycans. And so that right there is something that could very easily be, you know, they'll tell you it's a dissection, and then they'll ask you, what do you expect to see on histology? And that's the answer. It's right there in the text. So here's another look. You see this thing called cystic medial necrosis, and that's the buzzword that they'll use, you know. And so simply, cystic medial necrosis is going to be almost the same thing as myxomatous degeneration. And where have we seen myxomatous degeneration? Mitral valve prolapse. We know that it's going to be a whole bunch of extracellular matrix makes this mitral valve heavier, and so then it's more likely to break off of a chorda tendineae or regurgitate through whatever physical means. And so cystic medial necrosis is going to be the same bend. It's a proliferation of extracellular matrix. You've got too much extracellular matrix, except it's going to be in the wall of the aorta versus inside the mitral valve. And so here on the left, you see a normal aorta, and it's got a lot of elastin, and that's that dark stain. And then here on the right, here's a Marfan patient, and we know that Marfan's patients are also prone to get myxomatous degeneration. So here is the same sort of thing occurring in the aorta rather than the mitral valve. And you see these big gaps in between tissue, big gaps. And so that's why it's called cystic, is because it's like they're cysts. They're not cysts, you know, but they are cystic. And so they are in the tunica media. And so it is cystic medial degeneration, necrosis rather. So obviously the elastin in the affected wall is going to be much sparser, a lot less dense. One more time, there's this accumulation of mucinous ground substance. So because it's a lot of extracellular matrix, it's very similar to myxomatous degeneration. And that's what you would see on histology, is the accumulation of extracellular components. So it's associated, dissection is associated with Marfan. It's also highly associated with hypertension, imagine that, and atherosclerosis. So two general pathologies which cause endothelial damage. It's associated with bicuspid aortic valve because, a bicuspid aortic valve can compromise the integrity of the wall. It can dilate the ring of that aortic valve, the annulus of it, and then that can kind of mess up the ascending aorta downstream. Inflammatory diseases such as Takayasu arteritis, giant cell arteritis, so vasculitides. And then also, if you accidentally poke someone during a heart cath, that can predispose them to an aorta or get the ball rolling. And then pregnancy is another one that actually, pregnancy, there's an increased risk of dissection during pregnancy because you've got an increased plasma volume. You've got basically, like 1.25, 1.5 times your normal plasma. And so your aorta's got to stretch and distend a whole lot more than it typically does. And in fact, when you're pregnant, you're at risk for any aneurysm, far more at risk than when you're not. And then genetic disorders, we know Marfan's, we know Ehlers-Danlos type 4 involves collagen type 3 and Turner syndrome. So the gene for Marfan is fibrillin 1, and it presents with a widening of the aortic root on X-ray or CT, and it presents with a lens dislocation, ectopia lentis, and it'll just pop out following trauma. So aortic dissection can occur in that setting, and the question's probably fibrillin 1, or like what's the inheritance pattern. All these are autosomal dominant though. Ehlers-Danlos, that's a collagen 3 mutation. And what's characteristic about the EDS patients are that they're going to have translucent skin, see-through skin, prominent vasculature, and easy bruising. So Ehlers-Danlos typically affects the named arteries rather than the aorta, and Marfan is going to affect the aorta. And something I've seen in questions is a patient with one of these two disorders, one of these inherited collagenopathies, they kick it right out of nowhere, and they're typically in their 20s or 30s. And it could be a dissection, or it could be a mitral valve prolapse. Because if you get a mitral valve prolapse, you're going to volume overload the left side of the heart, and so that's going to stretch your conduction pathways, and so that's going to stretch your nerves, right? Literal neurons. It's going to stretch them, and so that hypertrophy created by the mitral valve prolapse can generate an arrhythmia, and the arrhythmia can lead to sudden death much more frequently than a dissection. So if you get a most likely question with a patient with one of these disorders and it's a sudden death question, then mitral valve prolapse is going to be the more likely mechanism than dissection. And then in Turner syndrome, we know what Turner syndrome is. Single X. Bicuspid aortic valve occurs commonly with Turner syndrome, as we said, stretching the annulus and predisposing that valve to stenosis. So most dissections have intimal tears. Well, they're not going to have adventitial tears, And typically, it's the vasovasorum that pops first. So the vasovasorum starts in the adventition and then goes into the media, right? And whenever there's small vessel damage to the vasovasorum, that can create tiny hemorrhages, microbleeds, right? And so microaneurysms. And so when these things happen, they'll happen inside the media because that's a very high pressure system, putting a lot of stress on those blood vessels. And when the vasovasorum ruptures, it can spill blood into the media, which can generate the medial weakening needed to predispose somebody to an intimal tear. And once blood gets into the inner layers of the aorta, it can travel anterograde or retrograde, so towards the heart or away from the heart. Most commonly towards the heart, I believe. And then if you picture a rupture in the arch of the aorta, and then you picture it traveling towards the heart, well, if it's high enough up on the arch of the aorta, well, maybe it's got to pass by the brachiocephalic artery to get to the heart. So the dissection can include and then occlude the brachiocephalic artery, and that'll lead to loss of a pulse in one limb only, your right arm. And so if a dissection reaches to the heart, what's a dissection? You're splitting layers apart. So if that reaches the heart, well, then the layer there is the pericardium, right? And so then you can get a hemopericardium leading to tamponade, and that's a medical emergency, and that's going to put you into diastolic heart failure because you won't be able to fill with blood all the way. And then the fact that you've got a giant rip in your aorta is just going to confound matters, and your output is going to be dropping very quickly, and patients going to have a rapid hypotension. So how do we classify dissections? You got a type A and a type B. Type A, Stanford, A for ascending aorta. That's it, nice and easy. What's the clinical picture? Well, patients got chest pain, right? Really bad chest pain. And if they catch it early enough, their vitals could be normal enough to make you think it's an acute MI. But this chest pain is not going to radiate up to the shoulder or the jaw, or downwards like myocardial infarction pain typically does. So this is going to be only a substernal pain, like right there in the front, if it involves the anterior sort of layer. If the aneurysm bulges out anteriorly, and if it bulges posteriorly, well, then you get this pain square in between your shoulder blades, right? And it's going to be a terrible pain. So patients can be hypertensive or hypotensive depending on the timeline. They're going to be hypertensive first because your body's going to compensate by spiking up epinephrine, but then eventually they're going to lose enough blood to go into shock. An X-ray is going to be the gold standard diagnosis of an aortic dissection. You're going to see a widened mediastinum, and it's going to be due to the fact that the layer is tearing off this aorta. And then a CT, an axial CT is really nice looking at dissections, but might not be, you might not have time to do that. So at the bottom of page 13, top of page 14, we're talking about obstructions to arteries as a result of dissection. Specifically with the cerebrovascular manifestations, limb ischemia with pulse deficits caused by involvement of a side branch orifice into the dissection, or obliteration of the lumen of a medium-sized artery by an expanding false lumen dissection, right? So the dissection is going to spread kind of like a Ziploc bag in both directions, right? And so it's going to spread like that, and it can involve the brachiocephalic, which a branch off of that is going to be your right common carotid. And so if those two arteries get involved, well, then you're going to be delivering less blood downstream of the involvement. So you're going to be hypoperfusing, your brain's not getting enough oxygen, and then your arm is not getting enough oxygen either. That's where the limb ischemia comes in. So that's and you can apply that to the left side too, and then you can apply that downwards too if it starts to involve their renal arteries, right? Maybe they go into kidney failure. Like, you can apply that to any artery that you could theoretically encounter off of the aorta. So then the differential between A and B. A's got super, super, super bad pain. A involves the ascending aorta, remember? And so syncope, that's fainting, due to a dysrhythmia. It can be due to a dysrhythmia. It can also be due, like we said, to a lack of oxygen, lack of perfusion of the brain. Dyspnea due to an aortic regurgitation. Obviously, if it's a type B and does not involve the aortic root, then you're probably not going to see an aortic regurgitation. Stroke and hemopericardium with tamponade, we've discussed those. And then a type B dissection. Typically, if it goes downward, then you're going to feel back pain rather than front pain, because remember your anatomy and know that the aortic arch ascends and then descends in a front to back manner. And so that's why the type Bs are more commonly back pain and the type As are more commonly front pain. So again, interscapular pain, loss of leg pulses. What's that? That's the dissection propagating down and involving a femoral artery, right? And then that's the fact that you have a hole in your descending aorta means that you're pushing blood into that hole, and all the blood that goes into the dissection is blood that's not going to your legs. And so there's that too. Paraplegia, same concept. Compromised renal or gut perfusion, same concept. So this paragraph right here, differential diagnosis, that is exactly how your patient is going to present in any question that you get about a dissection. It's going to be one of those two categories, right? Maybe a little bit of both. And so you're going to have to apply that and then work backwards and think, all right, what's the risk factor that predisposed them? What am I going to see on histology? That's the two big questions that can come out of here. Syphilis is the name of the disease, and the name of the organism is Treponema pallidum. And Treponema pallidum is a spirochete, which means that it's a spiral-shaped bacteria. So what color does a gram stain? Well, it really doesn't. So we've got to pick it up with these different tests, and they're called treponemal tests, right? Syphilis is growing more and more and more common very recently. Between 13 and 17, the rate of syphilis increased by 76%. That's pretty strong. Syphilis is a vasculitis. Syphilis infects endothelial cells. Syphilis only really infects endothelial cells. So it starts off in the small vessels distally, which is why in secondary syphilis you see a maculopapular palm and sole rash, because you have a lot of small blood vessels in your hand, right? But then as it gets worse and worse and the bacterial load of the spirochete within your blood starts to multiply and multiply, well, then you've got enough bacteria to where your aorta is going to be affected. And you might be thinking, well, why is the aorta infected? That's a really large vessel. And the answer to that is, well, they don't drill into the aorta, they drill into the vasovasorum, which are very small blood vessels supplying the aorta. So syphilis is a vasculitis of the vasovasorum. And again, in secondary syphilis, because it's a progressive disease, first you get basically genitourinary pain, and that's going to be it. And then as you progress into secondary syphilis, you've got a rash, it's copper-colored rash. Then you've got these things called condyloma lata, which are going to be big swellings on mucous membranes, so the mouth and the perianal region. And then tertiary syphilis is primarily characterized by this aortitis. And it's called a tree barking aortitis because that's what it looks like grossly. So the ascending aorta is affected in half of all syphilis aortitis cases, and that's because you've got the most vasovasorum in your ascending aorta because it needs the most blood because it's pumping against gravity, and also it's receiving the most high pressure blood out of the ventricles. The name of the lesion is endarteritis obliterans. So like end artery, right? What are the vasovasorum? They're end arteries. Obliterans, they're being obliterated. So the lesion starts around the vasovasorum in the adventitia. It's characterized by plasma cell infiltrate. That's an appropriate reaction to a bacteria. And then you've got reactive intimal proliferation and narrowing of the lumen. And the intimal proliferation manifests on a large scale as the tree barking appearance. It's plasma cells, not lymphocytes, right? Because lymphocytes, a whole lot of lymphocytes would mean virus or fungus, right? Or autoimmunity. But plasma cells, those are making antibodies, and those make sense in the context of a bacterial infection. So bottom of page 14, top of page 15, same thing. Like, here's the answer to the question if it gets asked, what do you see on histology? Well, you see a lot of swelling around the vasovasorum, you see intimal proliferation, and you see medial necrosis with destruction of medial elastic tissue and medial thinning. Here's what it looks like on an angiogram. I think that's an angiogram, yeah. Man, yeah, that's messed up. So you can see kind of how, like, down here is obviously a lot skinnier than up at the arch of the aorta. And so can you see how that ring around the aortic valve can start to dilate, lead to a regurgitation, lead to a volume overload, lead to a hypertrophy of your atria and ventricles, and then lead to maybe a one-sided arrhythmia of the heart whenever that conduction gets impeded? Yes. Oh, look, aortic regurgitation. We're going to talk about it here. So the regurgitation, again, everything stems from the high preload, the volume overload of the left side of the heart, because there's going to be a relative hole in the aortic valve. And here's what the PV loop looks like. And you can tell preload is going to be our component on the right side of the graph here. And it's getting dragged way off to the right. And then your end systolic pressure is also going to be a lot higher. And that means your pulse pressure is going to be higher, right? And so anyone with an aortic regurgitation, we know aortic problems, we can diagnose based on pulse. Well, not purely, but that helps, because if they've got an aortic stenosis, they're going to have a weak pulse. But if they have an aortic regurgitation, it's going to be a strong, strong pulse because of this high pulse pressure, right? And there's pressure because the left ventricle is always volume overloaded. So you also see an increased stroke volume, which is the width of the PV loop, right? So it's wider here than it is in normal, and so that's your increased stroke volume. You're going to hear this diastolic decrescendo murmur, and it's going to get louder on expiration, right? And that means whenever you breathe out, you make blood want to go into the left side of the heart. And so that's how you differentiate a left side versus a right side valve problem. And we had this concept appeared a couple of times on our last physio test. And you had to know that if it gets louder on inspiration, it's a right-sided heart sound because you're increasing venous return. But then if you breathe out, well, then what you're doing is basically increasing venous return to the left side of the heart. And so expiration, louder on expiration, left side, louder on inspiration, right side. Everything goes back to the high preload and aortic regurgitation. Ostial stenosis, coronary ostial stenosis. What does that mean? It means your heart arteries get narrow. And so obviously this can lead to ischemic symptoms, mimicking coronary syndrome. And then aortic valve dilatation, we've seen that. Anginal pain, again, from the obstruction of and the narrowing of the coronary arteries. Most common clinical symptom is chest pain. Diagnosis is based on the VDRL, or the rapid plasma reagent RPR test. Those are non-treponemal tests. And then your fluorescent treponemal antibody absorption, that's your FTA, ABS. That's a specific treponemal test. So remember, we can't just gram stain these things, and they're shaped like tiny little snakes. And we're going to treat syphilitic aortitis with surgery. So whenever the aorta swells, one more point, talking about compression of airways and recurrent laryngeal nerves. So when we're looking at this big wide aorta right here on the left, you've got a nerve, you've got nerves running. Let me go yellow. So you've got nerves running down and like going across the aorta, and then they're going like behind the aorta too. And then some of them go like around the aorta if you're like a pressure receptor, right? So nerves go all around the aorta. And anytime that this aorta swells up, you're stretching those nerves. And so the same principle here, anytime you stretch a nerve, you impede its function. That's why you can get the arrhythmias with the heart hypertrophy, and that's why you can get a hoarseness whenever you've got aortic swelling, because one of the nerves that goes down over the aorta is the left recurrent laryngeal nerve, which is intimately involved in speech. And so if that nerve gets stretched, well, then the patient can be hoarse. So that's a common presentation to let you know something, be it the aortic root or the atrium, is pressing up against the left recurrent laryngeal nerve. So that's aneurysms. Nice brief one. Thank you very much for watching. I appreciate it.